Wonderful. So yeah, thank you so much for inviting me to present our paper, and with a particular focus on the methods behind it and going into a bit of a deep dive into the rationale for those. I'm Dr. Amy Nelson. I'm an NIHR academic clinical fellow and an IMT3 at St Thomas's Hospital, and the academic component is with KCL. And I'm also a PhD student who's just submitted at UCL High Dimensional Neurology Group. And it was at UCL where a lot of this modelling work took place in collaboration with our collaborators in Bristol and Southmead Hospital. So I thought I'd start with a somewhat provocative slide on evidence-based medicine and ask the question to the audience, if we think that admission to hospital itself is an evidence-based practice. And if you somehow had to justify the rationale for why we do it, would we be able to say that it is actually an evidence-based practice? And I don't think it'll be possible to do a show of hands here, but of course we could justify the care of some conditions, that's well described in randomized control trials, but to justify the care in hospital as a whole, you wouldn't be able to do the study, and you certainly wouldn't be able to do the trial because no one would want to be randomized to the arm that doesn't get admitted to hospital with a severe, with sepsis, for example. And so if we were then talking about the levels of evidence for certain interventions in hospital, we'd probably refer to this Oxford Centre for Evidence-Based Medicine table, where we have gold standards of evidence, level 1 being RCTs and systematic reviews of RCTs, silver levels being cohort studies or quasi-experimental studies and systematic reviews of those, and then going down to level 3, individual case control studies or groups of case control studies. But the thing that I think is worth pointing out here is that even below that level 4, and just above expert opinion, is all of the studies in level 2 that are deemed to be poor quality. And I think that's pretty interesting because it's not just about the actual, study design, it's about how it's carried out. And the way we measure quality is not necessarily standardized, although there is a definition of what is meant by poor quality in this context. So the first two, I think, are fairly clear and easy to decide if a study has met the mark. So were the comparison groups well defined, and were the exposures and outcomes measured the same across the entire cohort? I think that's fairly easy to demonstrate. But the last criteria, did they fail to identify or appropriately control known confounders? That's often, I think, very tricky to demonstrate. And also, we could probably conclude that most such studies, at some point, if you sat and thought about it long enough, would have failed to control for some known confounder, which essentially places anything that's not an RCT right at the bottom level of evidence. And that's a problem because we can't run RCTs for many questions in medicine, whether that's because of practicalities, because of resource, they're incredibly expensive to run, or because it's not ethical to randomize because, for example, we don't have equipoise. And additionally, there are methodological constraints as to what an RCT can show. So we have this, they have an issue with showing heterogeneous effects is the stats term for it. But essentially, if a intervention cures 50% of people and harms the other 50%, then what will come out of an RCT is that there's zero effect. And that's clearly not true, not helpful, and not picking up the subgroups in which there's this heterogeneous treatment effect. And then, so that leaves us only with observational studies for some questions. And the issue is that it's very tempting, because it's the only evidence, to draw causal conclusions from associations. And I think that's just a very understandable human trait. We don't know an answer to something, and so we look for circumstantial evidence around it that doesn't necessarily demonstrate what we think it's demonstrating. And I put in brackets here, that's especially true when the studies say that they've adjusted for something, because they can say we adjusted for comorbidities, but what's actually happened is they've adjusted for hypertension, yes, no, or diabetes, yes, no. It'll be a small group of comorbidities. It won't be all, but it usually says we adjusted for comorbidities, which makes you think, okay, great, it's adjusted for it. And they won't have adjusted for HbA1c over the past 10 years, or the actual blood pressure readings of the past 10 years that would give you a sense of the degree to which someone had hypertension that was uncontrolled, for example. And the other issue with these studies, which many people are familiar with, is the idea that they're biased. So I've got here on the right-hand side a diagram, and that is often used to describe what we mean by mediator or collider bias, which are these terms in causal modeling to describe biases. So say X is a treatment, say it's aspirin, and Y is risk of a heart attack. We want to work out the effect of X on Y, but we only have GP records. And we can, look at all the people who have been on aspirin, and we'll see that their treatment allocation for being on to have aspirin, they're more likely to have received it or be prescribed it because, say, they have high cholesterol, or they've had, say, high cholesterol is B, and or they'll have had a prior MI, which will be A. And those are also independently associated with the outcome Y, having another heart attack. What we do when we do a clinical trial is we cut off all of the effects of comorbidities, these confounders A and B, by randomizing the allocation of the treatment X. And then we can isolate the effect of X on Y. That's what the trial does. And when we try to do causal modeling on observational data, what we're essentially trying to do is, without the benefit of randomization and running a trial in real time, is try to cut off the effect of these confounders through the data alone, which is a challenging task. So how does that apply to this scenario which we're talking about today? And particularly in major trauma. And as I was writing up, I think it was actually writing, the letter to the editor for this paper, I thought, oh, how many RCTs have there been in major trauma? And you can look at them because they're on this trials registry, and there were under 50 randomized control trials for major trauma ever in the world. And compare that to tens of thousands of RCTs for cancer. And there's a very, similar burden of disease and a very similar economic loss for major trauma and cancer. And yet there's a real lack of the evidence that allows us to guide treatment decisions. And when we look specifically at prior studies on pre-hospital intubation, because this is still somewhat of a contentious topic, depending on what centre you're working at and in which country. And my understanding is that it's, in the past 20 years become perhaps more contentious based on studies such as these meta-analyses in trauma. And you look at this forest plot on the right here, and we're, reasonably familiar with looking at forest plots. So on heading to the right on this x-axis is the survival favors ED intubation versus on the left, survival favors pre-hospital intubation. Hopefully you can see my mouse when I'm pointing this out. And it's very clear that if you pull the results of all these studies, there's a staggering clarity that survival is better if a major trauma patient is intubated in the emergency department. And so people would very reasonably look at this and say, well, of course, we should be very careful with who we're performing. We should be think of this as a potentially quite risky intervention. And these studies themselves do say that. They say, in red here, they've said the overall quality of evidence is very low. And yet in the conclusion, they say, even though the quality of evidence is very low, we should still perhaps be careful about recommending pre-hospital intubation. And that is a not particularly well motivated conclusion, because of course you are always going to find this effect. You could bet quite a lot of money that you would pull out this effect up front, because anyone who is intubated in the pre-hospital setting probably has more severe injuries. And if they have been intubated in the emergency department, then they have survived to the emergency department to receive intubation. So it's not really, this forest plot doesn't tell us what we really want to know about the effectiveness of the intubation itself, but just about the different populations who are intubated pre-hospitally versus the ED. And we do have one RCT on pre-hospital intubation. This is the Bernard study of patients with severe traumatic brain injury. The outcome that they looked at was neurological outcome, Glasgow outcome scale at 6 months. So they didn't set out to measure mortality, and it wasn't powered for mortality, but they did include that as a secondary outcome. And they did, in fact, find that people who were intubated pre-hospitally with TBI had improved neurological outcome. But because they weren't able to show that there was a mortality benefit, this is often cited as evidence that pre-hospital intubation doesn't have mortality benefit, because we have an RCT. But critically, if you look at the inclusion criteria, to be included in this study, you had to have a Glasgow coma score of 9 or less, and also intact airway reflexes. I mean, might well expect that the people who we think would benefit from pre-hospital intubation would be those without intact airway reflexes. And that's so important, because if you're looking at this sort of slightly safer subgroup where we can demonstrate equipoise, because otherwise we can't run the trial, then we're not looking at the whole group for which we would then potentially want to perform pre-hospital intubation. And I think it's important to say that with our study, if this had been added to these meta-analyses, we would have also shown that effect. of course, because that is what anyone would expect, is that those who are intubated at the early time point in major trauma have much worse survival than those who are not intubated early, because of lots of factors not related to the intubation, but related to the severity of injury and other indicators about the patient. So moving on to this study that we're discussing today. So this used data from Tarn. We looked at all presentations to Southmead Hospital in Bristol, which is a major trauma centre. And that was from 2012 to 2019, so over about 7 years, and it included around 6,500 major trauma patients. The way we set up the study is that we had a held out prospective data set that we didn't actually have access to until we'd fitted the models. And the models were fitted on data from 2012 to 2017. And this is a way of ensuring that the findings generalize going forward in time. We looked at 2 predictive outcomes, the first being 30-day mortality after trauma, and also early intubation, which is a combination of the pre-hospital and ED intubation time point. And I'll get into the reasons for that, for the reason why we conflated those two a little bit later. And then we also wanted to examine a single causal outcome, which was the marginal effect of pre-hospital intubation. Very importantly, as with the Bernard RCT, this study had exclusion criteria that was imposed by using Tarn data. So Tarn does not include those patients who died before reaching hospital, which is quite a big limitation when you were trying to work out a potential survival effect of a pre-hospital treatment. And so we also looked at a separate data set to quantify how many people died before they arrived at hospital and therefore were excluded who had received pre-hospital intubation. And over 7 years, we found that number was only 3. So it was not enough to change the result either way when we plugged it into the sensitivity analyses. But I think it's really important to quantify the size of that effect. We computed some summary statistics about epoch 1 and epoch 2, and they were largely similar, but there was a significant difference in that those in the 2017 to 2019 epoch were slightly older, so average age of 64 rather than 60. And then we used machine learning. And I thought I'd stop here and talk sort of intuitively about the clinical rationale for using machine learning, because I think it almost gets too much, the amount of machine learning papers that are being published in medicine, and I wanted to show why we did it, not just because it's trendy, if that makes sense. And I think this should hopefully make it clear. Can you see my pointer, or shall I just speak relatively?
No, you can see it. Yeah, okay, I can see wonderful. It fine.
So many relationships between clinical variables are what we call non-monotonic and probably non-linear. And yet most studies in medicine use logistic regression. And hopefully this diagram, I'll talk through it, shows why that is often not a good assumption to make. So on the right-hand side, we've got probability of intubation. White is very high probability, and black is very low probability. And we've got the combination of two interacting factors, GCS points dropped versus respiratory rate, and how that affects this how that affects the probability of intubation. So along the y-axis, and this is simulated data. I've defined this underlying relationship, but it's demonstrating what we would expect it to be. So as you increasingly drop GCS points, your chance of intubation increases. Okay. And on the other side, as you drop your respiratory rate, you become more likely to be intubated. And also, as you have increased respiratory rate, as you're tachypneic, you're more likely to be intubated. And perhaps having a lower respiratory rate is a little bit more associated with intubation than having a higher respiratory rate, because it indicates a different mechanism of injury. And you end up with this kind of relationship, which is called a non-monotonic relationship. And if you put the respiratory rate relationship with intubation into 2D, it would look like a U-shaped curve, right? If you try to model that, the actual underlying surface with logistic regression, and you fit it perfectly, the only thing that it can learn is this kind of a relationship. So logistic regression enforces linearity. And what that means is that you get this really useful thing out of it. You get odds ratios. And you can say that with every, for example, with age, with every increasing year, your risk of an MI goes up by 0.5%. And it's this unit increase, we call it the coefficient, that is learnt by the model and is really useful and is used throughout medicine for risk stratification models. But when you use logistic regression to model a non-monotonic relationship like this, all it can ever do is say that, okay, well, as you lose GCS points, you're more likely to be intubated. This is fine, but it completely loses the actual U-shaped relationship. And all it can capture is that roughly as respiratory rate increases, down here, you're more likely to be intubated. And then up here, if you already have lower GCS, if your respiratory rate is lower, you're more likely to be intubated. And you can see how that is very suboptimal, because that is literally the statistics that are being used to describe what's happening. Whereas if you use machine learning, you can capture a relationship like this, which is much more like the true underlying surface in terms of morphology. But it has lots of non-appealing properties also, in that it's kind of jaggedy. And there are some things that have been learnt here, in this corner, that are artifacts. This doesn't actually exist in the true underlying surface. But this is a much better estimate. This is a much better fit of the line to what the underlying relationship is. And so you can be more, and how could you tell this is a better fit without showing it visually like this, is that you would then ask the model to predict some other outcome that GCS and respiratory rate should be able to predict, and you would find that this would be a better predictor. And this, I hope, explains why machine learning has become so useful in medicine, because it allows us, without any kind of pre-specification, to learn tricky relationships for data that would not be possible to model with a linear model, without us doing any pre-specification. And we call this type of machine learning, these are universal function approximators. So that's what I mean by that. And this is talking about why the flexibility of the model is important, but it's also important neither to underfit or overfit the data. So if we look at this, I think the classification illustration is probably, well, they're both useful, but this is a classification problem. So we've got green and blue dots. If you draw a straight line to divide the green and the blue dots, and you say anything to the left of this line is blue and anything to the right of this line is green, you're missing out a lot of blues here, which is suboptimal. The optimal fit is actually a curved line in between these two groups, and that's allowing for some noise. So there are some blues on the other side, there's some greens on the other side, but perhaps these are spurious observations because of some kind of measurement error. And yet, if you would allow a machine learning model, to just learn all of the data, it could produce something like this, which is just as, perhaps even more undesirable than the underfit, where it's completely overspecified itself to the data, which includes noise, and it doesn't generalize to data outside this scenario. And this is the major problem with machine learning, is it's so flexible, it's so able to learn these kind of complicated relationships that it can pick up spurious noise, and it will learn that also. And so what we did in this study, which is very common practice, is something called cross-validation, where not only did we break the data into training data and test data, and this is prospective held out test data from 2017 to 19, but within the training data, we split it into a certain amount of folds, and we asked the model to, based on learning, say, fold 2 to 5, to make a prediction in fold 1, and then we can compare that to the actual values, and that gives us accuracy metrics. And it gets to learn over multiple slices while never testing on the same fold twice. And that's what we call model fitting. But to make sure we don't get that overfitting, we always test on held out test data. For this study, and I think this is an important point, in that I think we need clinicians to be able to properly do the data pre-processing. And so I've just pulled out some of, I can't zoom in actually, but I've pulled out some code from this study that we wrote. And there are lots of little decisions along the way with regards to these features that affect how well the model will fit. So on the left, for example, we had this issue with Tarn, that GCS sometimes wasn't just a numeric value between 3 and 15, but it could be missing assumed normal or missing assumed abnormal. And rather than just deleting those non-text or those numeric data points, you can say, okay, well, of course, missing assumed normal is 15, but what do you put as the best guess for missing assumed abnormal? And originally we put 3 here without really thinking. And then we stepped back and had a discussion, including with our collaborators in Bristol, and they rightly pointed out that missing assumed abnormal would be much better imputed as 8, which is less likely to sort of drastically shift the results in a certain direction. And it's much more clinically plausible that it would be sitting around 8 rather than 3, which is essentially dead. And then on the right-hand side, for example, there are lots of ways in which we can make the machine more able to use the clinical data in a useful way. So text data like pupil reactivity, brisk, sluggish, and absent, there's an order of how adverse those features are. And you can just encode the order in increasing amounts of how adverse that feature is. It doesn't have to actually reflect the underlying relationship, but as long as you encode that one is worse than the other, the machine can read that in an efficient way. And we did the same thing, not just for pupil reactivity, but for example, trap time. You don't actually have to encode the number of minutes of trap, how long a patient was trapped, but you can just put that in as an ordinal. And this is, 3 features out of hundreds. So we started with, there were 3,300 raw variables. And after doing all of this sort of processing, we got it down to the 210 pre-hospital variables, which are listed here, but will not go through. You can see them in the paper. And the type of model that we fitted is called gradient boosting machines that essentially make more and more, I think this is actually a similar model. It's not exactly the same model, that just takes better and better splits of the data and ensembles them, so you can make this kind of cut between pink and yellow. But what this model actually does is build a series of models that are trained to predict the residuals of the difference between the previous model's prediction and the actual values, and then it averages those all together in the way that you would calculate like wave superposition, if you remember from physics. But it sort of, yeah, I could go into lots more detail about this, but I don't think it's super relevant. I think the important thing to take away from the fact that we fit a machine learning model on this carefully feature engineered data is that we're able to demonstrate that 30-day mortality, which is in dark blue, is highly predictable from pre-hospital data alone. And even more predictable from pre-hospital data is early intubation, which is in this turquoise line. And the solid line is the held out test data in each of these cases. The dotted line is the average of the training data. And these confidence this is like one standard deviation across all of the splits in the training data. So it gives us some sort of measure of the uncertainty of the model within the training data. And the really nice thing about this is that the test performance, even though it's in the future on on-scene data, falls within those margins. I normally go into explaining ROC curves, but actually I think pre-hospital medicine is one of the specialties that uses ROC curves the most, and so I know you'll be very familiar with this. But just in case anyone hasn't seen this, on the y-axis we've got sensitivity, or the true positive rate. On the x-axis we've got 1 minus specificity, or the false positive rate. So this is literally the sensitivity specificity trade-off across various thresholds, and it tells you how good a predictor you have. So the closer to this right angle the prediction is, the more perfect an oracle the model is. Whereas if it's at this dotted line, then it's performing at chance, is the quick orientation. And we also did some other metrics of the predictive performance of these models, which show that, so the precision recall curve shows that it performs well even though it's imbalanced, and the calibration shows that the probabilities of the actual data and the model predictions match up. We can get some really interesting things from these models. So although we can't get logistic regression coefficients, we can still see which were the most important features for predicting early intubation versus 30-day mortality. And I think the thing to take away from these, sorry, I should orientate you to this. So These are called SHAP value plots. On the x-axis, we have to the left is a feature that is going to negatively predict early intubation. So anything in this direction means that it's less associated with no intubation, whereas anything on the right side is associated with early intubation. And the features, you can see these distributions are colored. So GCS being low is the highest, the most important predictive feature for the likelihood of early intubation being high. Whereas GCS being high is very much associated with there being no intubation, and so on. And I'll leave these up quickly so you can have a look through them. They're also in the paper. But I think the thing to take away is that these all make sense clinically. There are no real surprises here. And I'll not go into this in detail, but this is exactly the same as those underlying relationship plots that I showed you earlier with logistic regression versus machine learning. People often say that machine learning is a black box, and so to some degree that's true, but we can look inside the black box, and this is literally showing us the probability of intubation as seen by the model with GCS versus age. And we can look at all of these features in this way. So you can still investigate the relationship of the model and visualize it. And you can see that some of these relationships are indeed quite nonlinear. So what did we get to? So I'm just keeping an eye on time. What have we learned by this point? So we've done a machine learning study, and we can show that in major trauma, 30-day mortality is highly predictable from pre-hospital factors alone, as is early intubation. And that's interesting, but not necessarily useful. In fact, probably not useful at all as it stands. And so looking at this observation that pre-hospital intubation is associated with worse survival, early intubation is associated with worse survival. We then looked at the predicted groups of these machine learning models, now that they've been fitted. And this Kaplan-Meier curve shows that in those who are predicted to require early intubation versus not, the survivals actually overlap a lot with true survival in the early intubation and not early intubation groups. And yet, in those who were not intubated pre-hospital, in the pre-hospital setting, but were predicted to require early intubation, there was a big survival difference. And you could say, well, this is just due to underlying features about the severity of the patient's injury. So if we've predicted that someone doesn't need early intubation, well, then they've not been administered tranexamic acid, and they're not tachycardic, and they're not tachypneic, and their fall was less than 2 meters. Perhaps this is only capturing this. But then when you look at the survival curves of those who were intubated pre-hospitally, these differences in the type of patient, the survival differences collapsed. So suddenly, if you're not intubated pre-hospitally, that survival difference is big. But if you are intubated pre-hospitally, the survivals overlap. And I find this super interesting, and we were very tempted to publish at this stage without, because normally if you saw this result, you would publish it, and then you go on to do the randomized control trial to demonstrate the causal effect. But the problem is for all cause major trauma, and every single patient who might possibly need pre-hospital intubation, you will never have equipoise. You will never want your relative to be randomised to the non-intervention arm of the trial if they've sustained major trauma and are losing their airway. And these are the people in whom we actually want to measure the effect, because we want, for all sorts of reasons, to know, is this intervention effective? Should we be commissioning it 24 hours? So what we had at this point was a set of interesting observations that, again, were not necessarily particularly useful, although getting more towards the useful question. And so we'll go quickly through causal modelling, why that was needed here. So we know that we can't do the RCT, and yet we have this incredibly rich data set with 6,500 patients and all of their outcomes and the fabulous rich phenotyping that comes with TARN. So what is the best possible job that we can do with this observational data? And there are types of causal models that have been built for observational data, actually used a lot in economics, but becoming increasingly used in medicine. And we were actually approaching this, we'd got to this point in the problem right as the Nobel Prize in Economics for instrumental variables and these kind of causal models had been awarded. And we thought, well, why don't we apply this to medicine? And we were not the first people to do it, but this is sort of what led to the decision. And this diagram, it's similar to the diagram that we showed right at the start with the confounders and the colliders and aspirin and MI risk. But the issue is that, okay, it's all very well to specify this in a nice, neat diagram. There was someone had diabetes and someone had high cholesterol and someone had a previous MI, but what it actually looks like is a big mess of possible confounders and things that you want to adjust for, some of which you can imagine, some of which you can't possibly imagine, some of which you can't possibly measure. And it's a very tricky adjustment to make. And just because a study says that we've adjusted for age linearly, or we've adjusted for presence of diabetes, yes or no, that doesn't mean that it's actually adjusted for these confounders, though it's tempting to interpret it in that way. There are lots of types of causal models. An RCT is a causal model that is set up through its randomization and intervention design to remove the effect of confounders, as we discussed. Also more well known through in epidemiology is propensity score matching or inverse propensity weighting, where you look at propensity matching is probably easier to describe, but you look at someone's propensity to treatment who did receive it, and then you match it to someone who also had the same propensity, were administered tranexamic acid or tachycardic, you match them, but they didn't receive the treatment, and then you look at their outcomes and you see, was the treatment more associated with a good outcome or a bad outcome, given that you've matched these. And then you can also do adjustment for observed confounding, which is what is standardly done. Or you can combine these two in what we call doubly robust estimation models, where only one of those adjustments has to be correct for the estimate to be correct. So you get a double chance at the model being right in terms of its causal adjustment. How much time do I have to go through this? So this going in the forward direction, so the propensity model is the probability of receiving pre-hospital intubation given all of those pre-hospital covariates, tranexamic acid, tachycardia. We have already built that machine learning model. And then on the other way, you're estimating the outcomes, so 30-day mortality, given the fact that the person received pre-hospital intubation and also those covariates, tranexamic acid, tachycardia. And when you put those together, you get confidence-bounded causal survival estimates. And just to show visually on the right here what is going on with inverse propensity weighting. So here we have treated people in red and untreated people in turquoise, and the propensity to treatment from 0% to 100%. So the treated people were much more likely, based on all of those covariates, to receive treatment, right? That makes sense. And yet there was this surprising group here that had a very low propensity to treatment. They had a fall less than 2 meters, and they didn't receive tranexamic acid. And their GCS was a bit more normal than the other people, and yet they still received pre-hospital intubation. And on the flip side, there's this group of people who were very likely to need pre-hospital intubation and didn't receive it. And what inverse propensity weighting does is it fits a model that tries to redistribute the treated group and the untreated group along their propensities so that you can directly compare like for like based on those surprising observations. And it combines that with the outcome model that we described. I can take more questions on that, but I kind of want to get to the last few slides before we run out of time. When you fit doubly robust estimation, you're relying on assumptions, okay? So you have to agree that these assumptions are reasonable to agree that the outcome is licit. You know, the survival estimate of the model is licit. And so the assumptions of doubly robust estimation, first, similar to actually to the Oxford levels of evidence, good quality study, the treatment and the outcome have to be consistent across everyone. Two, conditional exchangeability means that a person could be just as likely to be in the treatment group as the non-treatment group after you've done this inverse propensity weighting, for example, and those populations are matching. So that's how good you've done the confounding adjustment. Positivity is that no patient had 100% likelihood of receiving pre-hospital intubation or a 0% likelihood of receiving intubation based on those pre-hospital variables that we've recorded. And for the intubation of another patient shouldn't affect an index patient's outcome. And this may or may not be true depending on demands on the system, but they're specified and they can be evaluated. The other thing that we had to do at this point was to turn this machine learning model that was predicting on 200 variables into something that could be used in the field. And so for this, we did a step called recursive feature elimination, where you take these 200 features, you put them in order of importance, and then you iteratively cut off the ends, and you look at the performance, and you can see here that the performance of this model started to level out at around 8 or 10 features here. So this was a model compression step. And whenever you sort of include GCS, verbal, motor, and eye as one feature, we got to an 8-feature model with still excellent performance, well, very good performance, according to ROC AUC. And we have put this into an app that you can actually interact with. The website link is there, but also it's in the paper, and we called it Intubate. And the idea is that at the scene, you could assess someone's risk of needing early intubation using this model, which is live. And when you use this Intubate model to predict risk of early intubation, those who are at high risk of early intubation have a 10% 30-day mortality reduction if they factually received pre-hospital intubation, which is equivalent to, which is 28 lives saved within the 2-year prospective test set. So we did all of this causal modeling on the test set only. Interestingly, even in the low risk predicted group, there's a slightly positive survival effect of pre-hospital intubation, which would indicate that the model is a little bit too conservative in judging who is at risk of early intubation. So there's probably people still within the low risk group, according to this model, who would benefit from treatment. And then treating everyone yields a 1% improved survival. But the very interesting and important finding is that in high-risk major trauma, pre-hospital intubation is associated with a 10% improved survival. I think the other thing to point out is just that the high-risk group is 10% of the total number. So this is not a 10% mortality benefit of everyone. This is 10% improved survival in 10% of patients. And then we did a sensitivity analysis. So you have to also agree for this model, for this result to be licit, you have to agree that there are no unmeasured confounders that are associated with both the outcome, 30-day mortality, and all of the covariates, with a greater relative risk that than greater than or equal to 2.5. And this is about the risk of smoking on cancer. And then when we plug that in to health economic modeling, so the quality of life adjustment EQ5D utility score in major trauma survivors is already published. And we worked out the average life years saved within this group. So average years to life expectancy, sex stratified. And we also extrapolated to UK trauma incidents from Southmead Major Trauma Centre. And that is equivalent to 170 lives saved per year. And the economic value of those 170 lives, because we know that trauma affects younger patients, is about 100 million per year using the NICE £30,000 per QALY threshold, which is the way that health interventions are funded. And of note, the UK-wide annual cost of HEMS is 62.5 million, so well below that threshold. So even if HEMS only provided pre-hospital intubation, it would still meet NICE criteria for NHS funding. There are many limits. Sorry, I know we're reaching time, but of course, the limitation is that we're only describing the catchment area that presents to Southmead Major Trauma Centre. We only looked at 30-day survival, and we didn't look at disability. And pre-hospital emergency anaesthesia with intubation is delivered as part of a package of care. And we didn't look at other aspects of that package of care. And of course, with any observational data study, there's a risk that there's unmeasured confounding that's possible. I think the main takeaway is that, aside from the survival effect, it's critical to answer the important question and not the easier one. Some questions need to be measured. They need to be answered using observational data, and we have to make the best use of that. And the last point is a political one, but it's more important than ever to defend the treatments that we think are efficacious, because if we can't show that they are, then we're in a time when services are more likely than ever to be decommissioned for political reasons. Maybe not so much in the UK, but certainly worldwide. And this is actually this was the pre-publication title of the paper, but it's available at Lancet Respiratory Medicine. Thank you.